let me know when I supposed to start.
Yeah, no worries.
Okay.
Good evening and welcome you all to this one of the interesting topic for any hand and wrist surgeon on distal radioulnar joint anatomy. This is one of the very interesting and intriguing topic, and also at the same time we call as the area of gray zone if you don't understand the biomechanics there. So for that we have a fantastic team of panelists, guided by Gustavo, Dr. Gustavo. I think I really should thank you for organizing this excellent team of speakers here today on the occasion of virtual education series organized by the Journal of Hand and Microsurgery. To add up to this evening, we have Dr. Zekil, Dr. Alex, Dr. Tuna, and the organizer and the convener, Dr. Gustavo Gomez. Welcome you all to this program. With this brief introduction, I welcome Dr. Zekil to talk about the distal radioulnar joint anatomy. Dr. Zekil, please go ahead.
Okay. Well, good morning to everyone. My name is Ezekiel Zeidenberg, and I'm going to talk about the anatomy of the distal radioulnar joint. But first, I would like to thank Dr. Sharon for the invitation. It is a pleasure for me to be a part of this meeting. But first, we need to understand that the DRUJ is not the joint per se, but rather the distal compartment of one larger joint, of which the proximal part is the proximal radioulnar joint. And as Carl Hager described in 1994, if one were to bring the PRUJ and DRUJ close together, a bicondylar articulation would be formed. Thus, these two joints could be looked upon as the forearm joint. We know that in the PRUJ, a true axial rotation takes place, while in the DRUJ, there is a swing of the radius outside the ulnar rim, and there is a translation and rotation. And according to Richard Gerber, the translation is so important that if we limit the translation of the DRUJ, the patient may lose around 50% of the apparent supination. The axis of rotation runs through the center of the radial head and through the foveal region of the ulnar head, moving from distal dorsal in pronation to proximal palmar in supination. And in this video, we can see how the distal end of the radius moves around the fixed ulnar head in terms of translational movement, not only rotation. And as Lynch had proposed in the early 90s, the stability of the DRUJ is provided by the contour of the joint surrounding ligaments and crossing muscles. These stabilizers are the bony structures, the TFCC, the ulnocarpal ligaments, the interosseous membrane, the extensor campi ulnaris and pronator quadratus, and the joint capsule. Regarding the osseous congruity, Hager demonstrated the discrepancy between the radius and ulnar articulation. The sigmoid notch has a radius of curvature between 50 to 90 millimeters centered at the ulnar styloid, and the ulnar head has a radius of curvature of 10 millimeters centered at the fovea. The incongruity of the articular surfaces create the geometrically non-constrained articulation at the DRUJ. In fact, in extremes of forearm rotation, less than 10% of the ulnar head is in contact with the sigmoid notch. For this reason, William Kleinman stated that the DRUJ is in fact an inherently unstable joint. The TFCC is the primary stabilizer of the DRUJ and is formed by the volar and dorsal radioulnar ligaments, the articular disc, the ECU subsheet, the ulnocarpal ligaments, and the meniscus. The radioulnar ligaments are the more important soft tissue stabilizers of the DRUJ. They converge from their separate origins on the radius to attach as a co-joint ligament to the ulna in two different locations. The deep component, or ligamentum subcruentum, is inserted at the fovea region at the base of the ulnar styloid, and the superficial part is inserted along the ulnar styloid itself. And over the years, there have been discussion about which of the radioulnar ligaments, the palmar or the dorsal, is the more important stabilizer of the DRUJ. Nowadays, we know that in pronation, the dorsal superficial fibers tighten as do the deep palmar fibers, while in supination, the palmar superficial fibers and the deep dorsal fibers both tighten to keep the DRUJ stable. So the fibers of one ligament that were taut in one position in the superficial layer were slack in the deep layer and vice versa. In this anatomical dissection, we remove the styloid insertion of the superficial ligaments, and we can see how in pronation the deep palmar fibers tighten, and in supination the stabilizers are the dorsal ones. The main reason why the deep fibers of the radioulnar ligaments play a key role in the DRUJ stability is because they form a wide angle of 105 degrees as they inserted into the fovea, and this arrangement gives the deep fibers a mechanical advantage to guide the radius around the ulna. In comparison, the superficial fibers form an angle of 56 degrees that is mechanically less effective, stabilizing the DRUJ on forearm rotation. Shin and colleagues recently published an interesting paper about the ulnar footprint of the radioulnar ligaments, and they found that the deep fibers have a broad marginal insertion at the fovea, whereas the superficial fibers have a circular condensed insertion at the ulnar styloid. In another recent paper published in the Clinical Orthopedics, in which Alex was involved, they assessed the general distribution in the TFCC of the nerve endings, and they observed that the articular disc and the ulno-lunate ligament are rarely innervated, which implies a mechanical function, whereas the radioulnar ligaments have a denser innervation, showing not only a mechanical role, but also a key role as a dynamic stabilizer of the joint. The extensor carpi ulnaris act as a dynamic stabilizer of the DRUJ. Although it seems reasonable to think that the ECU stabilizes the joint when it's located in a more medial position in pronation, Lida et al. Reported that it's mainly a stabilizer with the joint in supination. The extensor retinaculum itself has no insertion to the dorsal aspect of the ulna. However, the floor of the ECU tendon sheet has an insertion on the ulnar styloid, and according to Moritomo, intermingles with the dorsal radioulnar ligament, making this structure more relevant to the RUJ stability. The pronator quadratus, another stabilizer of the joint, was found to have two heads, the superficial and deep ones, with some anatomical variance. And in vivo studies using electromyography showed that the PQ was the main pronator of the forearm. The pronator quadratus is considered a dynamic stabilizer of the DRUJ, preventing diastasis of the joint during rotation of the forearm, especially in supination when the muscle fibers tighten. The ulnocarpal ligament complex is formed by the ulnocapitate, ulnotriquetral, and ulnolunate ligament. They are originated together at the foveal region and the base of the ulnar styloid, and they are extended distally like a fan to insert in the palmar aspects of the lunate, triquetrum, and capitate. They are confluent and quite often indistinguishable from each other. Moritomo described an important relation between the ulnocarpal ligaments and the palmar fibers of the ligamentum subcruentum. He hypothesized to use the remnant ulnocarpal ligament for cases of non-repairable TFCC injuries to stabilize the joint, taking advantage of this anatomical connection. The interosseous membrane is another stabilizer of the DRUJ. It's isometric and doesn't affect the forearm rotation and behaves biomechanically like a ligament, having material properties like the patellar tendon and stiffness comparable to the anterior cruciate ligament. The interosseous membrane transmits load from the radius distally to the ulna, and the amount of loads depend on the position of the elbow as well as the relative length of the forearm due to injuries or surgical procedures. The most relevant part of the interosseous membrane is the central band that has a width of 4 to 5 centimeters, and the fibers running from the radius are oriented in a 21 degrees ulnarly and distally direction. Over the last decade, there has been plenty discussion about the importance of the distal oblique bundle of the interosseous membrane in the DRUJ stability. The band goes from the distal ulna 5 centimeters proximal to the ulnar head and runs distally to insert on the dorsal inferior rim of the sigmoid notch. According to Watanabe studies, the distal oblique bundle of the interosseous membrane plays an important role when the dorsal radioulnar ligament is cut. However, there is a lot of controversy regarding the distal oblique bundle in the literature. Two important studies found the band only present in 40% of the specimens. So we know that plays a role in the stabilization of the joint, but it is so infrequent that it's difficult to get a final conclusion about the real importance of this bundle. This is a case example of a 51-year-old patient that suffered a motorcycle accident, initially treated for this radial head fracture, and the patient was referred to our clinic 3 months after the injury for persistent dorsal wrist pain, and the radiograph showed a longitudinal instability of the forearm with interosseous membrane injury and DRUJ instability. The comparative AP radiographs of the wrist show the widening of the DRUJ and the evident ulnar pulse variance. So in this case, I decided to shorten the ulnar, trying to stabilize the joint and to correct the ulnar calpar impaction. The shortening is supposed to work in this case, increasing the tension of both the distal oblique bundle and the ulnocarpal ligaments, but intraoperatively, after the shortening, the DRUJ remained unstable, so I decided to stabilize the joint with the tendon graft using a non-anatomical technique. This was the preoperative assessment of the joint before surgery and once the procedure was completed. These are the postoperative radiographs showing the correction of the ulnar variance, and this was the clinical outcome at 6 months, follow-up with no pain and restoration of full range of motion. So finally, the DRUJ capsule has been less analyzed compared to other stabilizers of the joint. However, Kleiman defined it as a continuous tripartite structure that blended seamlessly with the dorsal radioulnar ligaments and plays a role restricting the anteroposterior translation of the DRUJ. The dorsal aspect accommodates the distal ulnar impronation, and it is located underneath the floor of the fifth compartment, while the palmar part is in close contact with the distal ulna in supination and receives fibers from the deep pronator quadratus. In this video, you can see how the anterior capsule is taught in supination, and this is important because it's the reason why we perform a volar capsulectomy for patients with supination contractures of the wrist, and the dorsal capsule is taught in pronation. So in summary, we need to remember that the DRUJ is the distal part of the forearm joint, and it is stabilized by the osseous congruity of the joint, the TFCC, the ulnocarpal ligaments, interosseous membrane, joint capsule, and the dynamic stabilizers, including the extensor carpi ulnaris and pronator quadratus. I would like to thank the anatomy lab of the Kleiner-Kutz Institute, where I performed some of the dissections that I show, and also to the anatomy lab of the University of Buenos Aires, where I work with my father, not only in the lab, but also in the OR. So thank you.
Thank you, Dr. Ezekiel, for your excellent talk about the surgical anatomy and the role of stabilizers, especially on the dorsal and the ulnar side. In the video, I mentioned about the role of capsules in pronation and supinations. Thank you. For all of us, we know that Dr. Ezekiel Derenberg is a past fellow of Kleiner Institute, and also he has attained the European Diploma in Hand Surgery. He has a lot of publications, more than 30 indexed in all international publications, and then he has been the editor for various international hand surgery journals like Journal of Hand Surgery American and other journals. Thank you once again for joining us. Next, I invite Dr. Gustavo Gomez Rodriguez, a very close friend of mine, who is the person who is the man behind this program. Of course, I should thank him for arranging such a wonderful faculty in a short notice of time. He is a past fellow from Mount Sinai in New York, who worked with Dr. Michael Hossman, hand surgeon specialist. He is the professor, teacher, and director for fellowship programs in the Hand Surgery Association of Argentina. And at the most, I could say, is the advanced faculty and a very experienced arthroscopic surgeon, especially in terms of wrist problems. Welcome, Dr. Gustavo, and please start your presentation.
Okay, thank you, Jerome, for the invitation and the generous presentation. It's a pleasure for me to be here with you and with these greater speakers. First of all, I would like to highlight some concepts. As Ezekiel explained it, the TFCC has two fascicles, a distal fascicle that goes to the styloid and a proximal one that goes to the foveal footprint of the ulna, which is marked with the arrow. And nowadays, thanks to Andrea Tse, it's very clear that this deep fascicle is the most important stabilizer. Of course, it would be great if all patients with a TFCC tear have this MRI, but sometimes the image we see in the office, it's very confusing. There are some others that who talk about the MRI, and they say that it's not a reliable study to rule out injuries of the TFCC. So physical examination is the key to determine the presence of distal radioulnar joint instability. As Ezekiel explained it, we can see how the ulnocarpal ligaments are born from the palmar radioulnar ligament going to the lunate and to the triquetrum. So when we apply radial deviation, we can see how the ulnocarpal ligaments get quite tight. And this is very important because if we perform a Ballottement test in a neutral position, we can find a greater laxity than in a radial deviation, where we can see how the foveal attachment becomes more taut, so we gain more stability. But this doesn't happen when we have a foveal detachment, so we can find more instability during Ballottement test, even during radial deviation. And that's why it's recommended to perform Ballottement test in neutral position and radial deviation. Here we have a normal wrist, and you can see how more stability with radial deviation. But in this injured wrist, prior to the repair of the TFCC, we can see how with radial deviation, it still remained very unstable, as you can see here. It's very important to remember, as Ezequiel told us, that the extensor carpi ulnar is a very important dynamic stabilizer, and we should always rehab this muscle, because sometimes patients gain very good stability with dynamic stabilizers and avoid going to surgery, like this case. The pronatus quadratus, as Ezequiel told us, is a very important stabilizer too, and it's very important to rehab this muscle prior to surgery, because in this level 3 study, authors found that lower quadratus muscle cross-sectional area on the MRI was the most factor negatively affecting clinical outcomes. During arthroscopy, we use, of course, the hook test to evaluate the foveal attachment. So you can see that sometimes we can elevate the TFCC, and the TFCC can contact the triquetrum. We use too the trampoline test and the suction test with the shaver, as you can see here, to evaluate the distal fascicle tears. And this is the point where we evaluate the quality of tissues we have. To continue with the repair, we must have a very good quality of tissues. Otherwise, we must think in a reconstruction. In this level 2 study performed by Ricardo Lucchetti, they found that the hook test is enough to determine a foveal detachment, so the distal RadioUlnar Joint arthroscopy is not always necessary. And this is very important because it allows us to find a simple way to the goal. So I will show now a simple technique for TFCC repair. As I said before, it's not always necessary to perform distal RadioUlnar joint arthroscopy. We can reach, because we can reach the fovea to work on the footprint through the pre-styloid recess, just the same place we introduced the probe to perform a hook test. After that, we perform 1.5 centimeter proximal to the styloid tip. We perform 2 transosseous tunnels to the fovea. We usually use 2 parallel 1.5 temporary key wires, and then we pass 2 needles through those tunnels using those PDS to pass a fiber wire. So this is the view we have with arthroscopy, and we pass one tail of the fiber wire with the loop of this PDS through one of the tunnels, and then we use, this is the vision we have while we are performing the arthroscopy. So we have now one tail of the fiber wire passing through the one of the tunnels, and then we use the loop of the other PDS to pass the other tail of the PDS. So then we have a loop above the TFCC, and we can squeeze the TFCC to the foveal footprint. This is the arthroscopy passing the other tail of the fiber wire. And then we have the loop, and we squeeze it, we squeeze the TFCC to the foveal footprint, as you can see here. Then we fix the fiber wire to the ulna using a knotless anchor, as you can see here. And this is the final configuration. And we can see here the stability we achieve with this technique, with a negative trampoline test and a negative hook test. we are not able now to introduce a probe below the TFCC. Look at the preparation having the bees because we are really trying to get the probe below the TFCC. Okay, and this is the difference between before and after this procedure with 2 fingers Ballonman test. You can see the difference. And we protect this repair with this splint for 3 weeks after surgery. Okay, if we analyze studies which compares open technique with arthroscopic techniques, we can see that there is no differences between them in terms of clinical and functional outcomes, but a shorter time and a more feasible in terms of technical facility was found for arthroscopy technique. And this is quite interesting because really, if we have a trained team with a fellow and a PA, a physician assistant, we can see how it can really take between 25 or 30 minutes to perform the entire procedures. This is a real-time repair, and notice how there are several hands appear on the screen while we are passing the fiber wire through the bone tunnels. This is an arthroscopy we perform with my PA Paula and my fellow Nicolas Irigoitia. So if you have a trained team, you can really decrease times of surgery. And there you have the loop. It takes just 1 minute to change the needles for the loop of the fiber wire. Okay. In this biomechanical study, authors compare a repair using a direct anchor on the fovea versus transosseous tunnel versus transosseous suture. And they concluded that when making decisions about TFCC foveal repair, transosseous suture technique may provide better biomechanical strength than the direct foveal anchor. Matsumoto and colleagues studied which one was the optimal suture placement and bone tunnels location for the TFCC foveal repair. They analyzed 36 combinations of suture location in TFCC and bone tunnels position on the ulnar, and they found that tunnel position was more important than the TFCC suture location. So we should always try to position the tunnels as close as possible to the isometric point. To end, as a conclusion, we must give priority to physical examination, rehab dynamic stabilizers, and always have a good quality of tissues prior to surgery. I recommend starting with the simple, without complex techniques. Remember that it's not always necessary to enter to a distal RadioUlnar joint. It is also important to remember that many authors support the idea that transosseous tunnels are superior, and when we do it, please try always to find the isometric point. Thank you very much, Jerome. It's a pleasure to be here.
Thank you, Gustavo, for your detailed and very simple way of explaining this procedure. I think we really enjoyed and I learned a lot of technical aspects, especially the final points. I think, as you mentioned, I think it will take only 20 minutes in your hands if you have your assistant and a fellow who can help you. I think there's a great surgery to watch. Thanks again, once again for your nice presentation. I invite Dr. Alex, who is the chair and head of the department of the University of Barcelona. He has been the executive committee member, treasurer, and in charge of the Federation of European Society of Surgery of the Hand, and also an advanced faculty in the field of arthroscopy. I think we will have a great pleasure in having him. I invite Dr. Alex to talk on this subject. Please go ahead, Dr. Alex.
Okay, thank you. Thank you for this invitation. It's really a pleasure, although it's siesta time in Spain, but it's really a pleasure to share a session with good friends. I'll try to share a vision about if it's possible to treat DRUJ arthritis, but without the use of implants. And as this will be covered in another talk. So when talking about DRUJ arthritis, these are the three questions that come into my mind. The first one, why it happens. The second one, how to diagnose it. And the third one, how can be treated. Well, why it happens, it doesn't have an easy answer, actually. If you think about it, the generation of the DRUJ can be caused by joint incongruence, especially in the convex part of the joint in the ulnar head, because of inflammatory conditions, or because of deposition diseases, mainly chondrocarcinosis or pseudogout. But although some arthritic DRUJs may add some laxity, this is not the most common final end of long-standing instabilities. When talking about diagnosis, clinical exams help and should be the first step, always. Pain or painful crepitation appears when the ulna is pressed against the radius and the forearm is passively rotated in the so-called radioulnar compression test. Radiological diagnosis of DRUJ arthrosis is many times easy, but not always. Early radiographic signs of degenerative arthritis of the DRUJ typically occur in the proximal portion, in this area here, in the proximal portion of the joint. Osteophytes from along the proximal margin of the ulnar head, whereas the sigmoid notch often is spared. It's much more difficult to see the changes. CT can detect the bony changes more clearly, and MRI is able to see chondral lesions or concomitant synovitis. Obviously, direct vision is the best and more objective way of detecting chondral damage. Although the cartilage is perfectly seen with this anatomical approach described by two of our mentors, nowadays arthroscopy is the best tool to evaluate the joint and surrounding structures, surrounding intracapsular structures status. As in this DRUJ arthroscopy through the DRUJ portal of a left wrist from the person who teach me to scope the wrist, which is Mireia Splugas, my colleague. And remember finally that DRUJ arthritis may coexist with other conditions. From my point of view, probably impaction is the most frequent association. Finally, how to treat DRUJ arthritis. We will see the different options for surgical treatment. But remember that as any arthritic condition, conservative treatment should always be the first option. Joint innervation is a procedure many times forgotten. And few information is available about innervation of the DRUJ. Just a classic paper published 20 years ago with well-known names, this one here, and a very nice recent paper from Austria. The first one is mainly focused on the TFCC. We also did some studies on that, as Ezekiel showed. But the second confirms that the DRUJ innervation is complex and involving the anterior and posterior interosseous nerve and the dorsal sensory branch of the ulnar nerve. In these fantastic preparations taken from the paper from Graz, Austria, you can see some articular branches going to the joint from volar and also from dorsal. Our experience with DRUJ denervation is really small. We didn't have a great experience with some cases years ago, But seeing them retrospectively, maybe that was because those patients had also added some degree of laxity. This is a recent case done with my friend Guillaume Salva. The patient is a 57-year-old waitress that had this arthritic DRUJ with a previous shortening osteotomy and wanted to have done the less aggressive procedure possible. So we performed a denervation plus synovectomy plus osteophyte resection. And right now, 1 year after, she's really happy with the result. I'm sorry I haven't found the surgical pictures. Resection arthroplasties have been the most popular treatment option for DRUJ arthrosis during many years. There are several modifications from the original procedure described by Darac, mainly a match resection with the ulnar part of the distal radius or some kind of soft tissue interposition. Some technical tips may help to improve the results obtained with resection arthroplasty in the DRUJ. The first one is doing the resection as distal as possible. By that, any contact between the remaining distal ulna and the radius will be in a relatively flat, triangular shaped area which is better prepared for contact, and not in a ridge that actually serves for insertion of the interosseous membrane, as Ezequiel has shown. Also, shaping the distal part of the ulna in order to match the opposite surface of the radius will increase the surface area for radioulnar contact and may decrease the possible painful compressive forces concentration. If nature shapes the ulnar stump with time, why not doing it from the beginning? Finally, the surgical procedure must be planned in order to preserve all the static and dynamic stabilizing structures of the distal ulna. So if it's possible, reinsert the remainings of the TFCC, keep in place the pronator quadratus muscle, keep in this anatomical place the ECU, and maintain the insertion of the distal oblique bundle if this patient has it. Just one case to illustrate resection arthroplasty. This 36-year-old male with 3 previous surgery that ended in a painful DRUJ with limited motion with this evident chondral lesion in the CT. It's here. In which a matched distal ulnar resection was performed, and this is the clinical result more than 10 years after. I don't know why the videos are not playing, but he's doing pretty well. Well, what does literature say about that distal ulnar resection methods? Well, these are the most recent papers about long-term results of distal ulnar resection. Although the second one just included patients after distal radius fracture, satisfactory good long-term subjective and objective results are reported. In these papers, radioulnar impaction was seen in most of the cases, but did not influence clinical outcomes. And as in all joints, arthrodesis is an option in arthropathy. The problem with the DRUJ will be the great functional loss of pronosupination in cases of forearm arthrodesis. This is why a portion of the distal ulna is resected in Sobeka-Pange procedure. It will allow recovering the forearm rotation. Another theoretical advantages may be maintaining the ulnocarpal ligaments, maintaining the normal shape of the ulnar side of the ridge, which is a complaint that some people with just simple resection have, especially females. And also increasing the bony surface of the distal forearm has been mentioned also as an advantage, but I don't think this is a real great advantage. The reason why this technique has fallen in disuse in several countries is because 3 complications that can occur directly related to this procedure. The first one is non-union of the arthrodesis. The second one is fibrous or osseous union at the level of the pseudoarthrosis. And the third one is a painful instability of the proximal ulnar stump. Non-union is easily avoided by taking some care about the things you see on the slide. You need cancellous bone to be exposed. You need compression as in any fusion or fracture. And you don't need to have cortical bone in the middle of the two pieces of bone that you want to have fused. So don't use the segment of ulna as a bone graft when doing a Sobeka-Pangi. Fibrous or osseous union at the pseudoarthrosis can be prevented if during the procedure a small ronger is used rather than a saw. Soft tissues are treated with care if you remove bone debris and periosteum. There's no need to interpose any soft tissue at the level of the non-union. As far as you have motion in this area, you won't have fusion again. And finally, the most worrying complication is painful instability of the ulnar stump. And this can be diminished by doing the osteotomy really close to the head of the ulna, leaving the smallest bone defect as possible. Then the contact will be in an area that is better prepared, as mentioned, with simple resections, and then less disturbance of static and dynamic stabilizers will occur. This is a case of a 61-year-old female with a limited painful pronosupination due to an arthropathy. Look at the X-ray, at the CT scan, the MRI, and the amount of degenerative changes. We decided to perform a Sobeka-Pangi procedure, and she's doing fine 7 years after. See the remodelation of the proximal stump in the X-ray. I revised more than 15 years ago the cases of Sobeka-Pangi performed in Kaplan Institute. It was 70 patients. Satisfactory results were obtained in most of the cases, but grip was still lower than the non-operative side as reported in many study, and few patients complained of symptomatic radial impaction. Actually, from the 5 patients that had this condition, just 1 required surgery, 1 on 70 patients. This is what is said in the literature. One should expect satisfactory good results in the long term. When you compare it just with resection, there's some papers saying that Sobeka-Pangi is better than resection, and there's another paper saying that it's not worthy doing a Sobeka-Pangi because it's a little bit more complex, and also because of another complication, which is you have the ulnar stump a little bit more proximal, and by definition, this may end with an instability or with a painful impaction. And finally, just one word about replacement. I know this is not the issue of my talk, but yes, we do perform DRUJ implant replacement. We have experience in partial hemiarthroplasties, in hemiarthroplasties, and in total arthroplasties. So this is not, I'm not saying that DRUJ implant replacement is not a good option in many problems of the DRUJ. Just it was the topic of my talk. One word about radial impaction, which is the most worrying complication about any surgical treatment in which you resect the distal ulna or a portion of the distal ulna. The ulnar head excision, as I mentioned, that will create a radial impaction. The thing is that it's not always symptomatic. And this is going to be happening in all the procedures that I've been mentioning during the talk. Complete resection or DARAC, Sobeka-Pangis, Bowers with interposition or ulnar resections, this as the one described by Watson. So all these procedures, all of them create a radial impaction. Many times this impaction is asymptomatic. The problem is that it's difficult to predict, so you really don't know which patient is going to develop a symptomatic impaction. And the other problem is that when you have it, it's very difficult to correct. It's like a little bit like the sword of Damocles that these kind of procedures have. You know, Damocles, he had a sword just very close to his head, and the sword was just hanged by a horsehair, so it was quite easy that it could fall down, and if it fall down in his head, well, you can imagine what is going to happen here. So how can you manage symptomatic radial impaction? These 3 ways: conservative treatment, surgical treatment without implants, or with replacement. The most important thing is to prevent it. And one thing that I want to emphasize from this talk is when you do a distal ulnar resection or a sobeca-pangi, follow the steps that I've mentioned at the beginning. So try to do it as distal as possible. Try to prevent all the stabilizing structures to the distal stem and the DRUJ. Conservative treatment is something in which we work a little bit several years ago. If you think simply about the structures that are, the dynamic structures that are acting at the distal ulnar stem, you have one muscle which is deloading the impaction of the ulnar stem, which is brachioradialis, because it pulls the radius, at least in neutral pronosupination. So reinforcing of brachioradialis may be one thing that you can do in conservative treatment. And the other thing that you can do is decreasing the force of brachialis muscle, because this is an ulnar flexor that it's going to make the ulna come a little bit closer to the radius in case you don't have an ulnar head. So we decided to try to inject with Botox some patients with symptomatic ulnar stem, and they really improved. In those patients, we performed a tenotomy of the brachialis, and it worked. The problem is that brachialis has very wide and very distal tendons. Some of these tenotomies scarred back, and some of the patients had some pain of the impaction back again, but most of them did pretty well. The second option is doing some surgical procedures without implant. We haven't had good results with that, actually, neither with FCU or ECU tenodesis. Probably the main reason is because when you do some activity with strength on the distal forearm, you place your hand in ulnar inclination, and that means that the tendons that you use for tenodesis, they are not going to be working properly, and this is not going to stabilize the stump. And we didn't have also a good experience with interposition, although I know there's some people reporting that they really had good experience in avoiding symptomatic impaction. And finally, replacement. When doing surgery to radial ulnar impaction, I think this is the most logical option. Hemiarthroplasty, I think it's a problem because you have to stabilize it by some means, and sometimes this is not so easy. This is a very clever option. It was published by Diego Fernandez, who is a very good friend of mine. The problem is that it's technically demanding, and you should use one specific implant, which is an ulnar head replacement. It's spherical and made of ceramic, and then you have to create a socket like a new acetabulum in the proximal part of a distal of a sobeca-pangi procedure. And probably I think the best solution for treating radial ulnar impaction when it's symptomatic and you have tried many things, it's by using a total arthroplasty, which I think we're going to be told in a few minutes. And just one thing to share, I don't know if that's true. This is something that I've been looking in clinical experience. If you have a resection arthroplasty and you have motion at the level of the wrist, I think this is much better tolerated than if you have a wrist fusion. And I really don't know why. I have to think about it, but it's something that I've seen many times in clinical practice. So just for ideas as a conclusion, the first one is that DRUJ arthritis is not really very common. It's not the most common problem in wrist when patients come with ulnar-sided pain. The second one, if you try to perform a resection of the distal ulna or a sobeca-pangi procedure, I think there are valid options. So you are not doing something horrible. You have to select your patients and you have to do the proper technical procedure, like the tailors. You have to tailor your treatment to the patients. That radial ulnar impaction, or if you want to call it the painful proximal stem instability, radial ulnar impaction appears almost always, but it's frequently asymptomatic. So pain is not always there. And finally, if you have this condition but you need treatment and you have tried all conservative treatment as possible, I think the best option is to perform a total arthroplasty. Thank you.
Thank you, Dr. Alex. I mean, we enjoyed every slide of your presentation, and all of them are really, very useful for all our listeners here. Right from the fact you said, compare between the direct and sobeca-pangi. the problems with the radio-ulnar impaction and how to manage this. And more interesting was the picture of sword of Damocles, who had always threat while treating the DRUG function. I think we have a lot of questions based on the entire topics we'll take at the end. Before that questions, we have the last speaker of this evening, Dr. Tuna. I think he needs a special mention about his career. I mean, you name the joint or name the finger and the hand, he has a lot of work in it, right from the forearm, hand, the PIP joints, the wrist, and of course he's the lead surgeon in the transplantation program in Louisville. He has been a teacher for more than 400 students, international students in his university. I think we are really honored to have such a great teacher and a great surgeon from University of Louisville. A lot of laurels and a lot of works behind him. Thanks, Dr. Tuna, for joining us. Please go ahead with your presentation.
Thank you, Dr. Jerome, and thank you for the invitation and also organizing an interesting topic. And thanks to Dr. Zeidenberg in his help as well. And excellent presentations we have seen so far. And I will come to the, I guess, last topic, which is the total DRUJ implant arthroplasty. Now, first of all, I have nothing to disclose related to the topic or to the companies that provide these. So when I think about DRUJ pathology, there's impaction between
Sorry to disturb you. Sorry to disturb you. Can you make your presentations? Can you share your presentations?
Okay, sorry about that.
No problem.
I thought I did.
Perfect.
Is it better now?
It's perfect. Perfect. Please go ahead.
Okay. Let's put it in the full mode. Yes.
Yeah.
All right. So when I think about DRUJ pathology, what comes to mind is impaction between the ulna and the corpus. And then there's a problem of impingement between the radius and the ulna. And also instability is a big problem. When forces pass from the hand to the forearm and to the upper arm, there has to be stability. And if there's joint loss and if there's bone spurs, etc., we talk about arthritis in that. So we also see symptoms as pain, stiffness, but also the biggest issue is the weakness, not only in grip strength, but also in carrying things, because the forces come from the hand to the forearm to the radius, and then from the radius through the PRUJ and DRUJ, it goes into the ulna, and then it will be transferred to the upper arm. There has been several salvage procedures described for this radial joint problems. Dara, Soveka-Panji, Bowers, and Watson. And there are ulnar head replacements as hemi-arthroplasty. And then as it stays unstable, there are brachyradialis wraps and tendon stabilization described. DRUJ arthrodesis was described as a terminal procedure, or sometimes you can really do nothing and you end up with a one bone forearm, which are very disabling procedures. So as we look at the earlier mechanical studies, I think half of the problem was studied. They, as you know, most of these studies stabilize the elbow and the forearm, and then will apply forces from the hand to the forearm. And these show that compressive force across the carpal ulnar articulation tends to have a separating effect on the radius and ulna. And TFCC was seen as a stabilizer. But as we understand that the radial-ulnar impingement between the radius and ulna, as discussed tremendously by Shekhar and Weiss, shows that although we see space there, that space doesn't stay. And however smooth the surfaces are, they start hitting each other as soon as you have a little bit of weight in your hand. So most of these patients do pronation and supination function well, but when it comes to lifting things and carrying things and gripping, problem starts. And I agree that many of them do okay, but they are not really using their arms as much, because the ones that use, we see problems. I'll start with my indications as my algorithms, and if there's ulnar impaction, and if there's a positive and neutral ulna and there's no arthritis, I prefer ulnar shortening. And it's a very well proven method. It stabilizes the DRUJ even further. It makes it more stiff. If there's proximal arthritis, I will still do the ulnar shortening and try to bring the arthritic surface to an area that is basically quiet, so that the bone doesn't rub on bone. So ulnar shortening will work on these patients as well. If there's negative ulna and there's no arthritis, I prefer arthroscopic debridement. And if there's distal arthritis, which is a very rare case, but as in this one, I prefer the arthroscopic wafer procedure to treat ulnar carpal impaction. And you can see the amount 1 or 2 millimeter excised. So if there is ulnar head osteoarthritis or sigmoid notch arthritis with any ulnar variants, and there is no distal RadioUlnar joint stability, there's the solution is the Shekhar prosthesis. If there's missing ulnar head and rheumatoid arthritis, again, we jump to Shekhar prosthesis. The DRUJ is stable, but there's arthritis. I thought in the past that ulnar head surface replacement is a very good option. So in this example, 56-year-old male, bilateral injuries, and you see the arthritic DRUJ. He came to me after the ulnar shortening, and I thought the DRUJ replacement could be an option because the DRUJ was stable. I mean, so ulnar head replacement with this Beckenbauer prosthesis, which preserved the TFCC. But later, as you see here, basically the prosthesis digs into the radius and becomes a very painful implant. And that's when things get into trouble. So it works okay for several years, but as they lift in this young man, not the same person, but this is a different one, you can see how it's digging into the radius. So there needs to be some support on the sigmoid notch area. 62-year-old female, 3 weeks after a fall, she's totally unstable. Then we have this problem. If you're not careful with this, there's a reverse sigmoid notch. So instead of the normal angle of the sigmoid notch going from distal to proximal, giving more space for shortening, we have an opposite effect here, where if you do the shortening, you will basically increase the contact forces between the radius and ulna in the reverse sigmoid notch. And you, with the arthritis, things will even get worse. So a patient like this, do whatever you do, you will increase those forces, and then it will turn into arthritis. So I thought we could do the Beckenbauer prosthesis in these, but again, unfortunately, that got out of my algorithm. Now I will go with the Shekhar implant directly, even for those. So what is the indication for Shekhar implant arthroplasty or total DRUJ arthroplasty? Well, primary osteoarthritis, post-traumatic osteoarthritis, rheumatoid arthritis, any arthritic problem with instability, any salvage procedures that failed, as you see in these. I still like going through a hockey stick incision over the fifth compartment and go between the sixth and the fourth compartments. But I believe Dr. Shekhar's latest recommendation is to go completely ulnarly and then distally go radially. Regardless, you expose the ulnar head and the distal RadioUlnar joint. It's important to prepare your flaps if you feel like you need to interpose some tissue between the implant and the extensor tendons at this point. Then you expose the distal RadioUlnar joint. One of the most important things is after you cut the ulnar head, you expose the ulnar surface of the radius, and there's a flare in the sigmoid notch that will need to be removed, because this basically causes one of the most common errors with this implant, because if you leave the volar bone, it will keep pushing your implant to a dorsal location. So once you align it well with the sigmoid notch and on the correct lateral view, you put your implant mostly volarly and perfectly in that position. Then you do your drilling and then apply the radial plate. Once you push the radial plate in place, you can finish your osteotomy line as planned preoperatively. Then you put a drill guide, and then you will basically ream the canal and then rasp it and then insert the stem. And it's important to keep the measurement in place so that the ball that connects the tooth system and the cover that connects the radial plate and the ulnar stem are aligned well, and nothing short, nothing long. And you put the cover, and then in surgery, you come up with full pronation and full supination. What I do is I use a short arm splint for 2 weeks, and I don't allow for any lifting for 6 weeks, but I will start physical therapy at 2 weeks and begin strengthening at 4 weeks. And this is a perfect example of the full range of motion and great strength achieved. I asked for the numbers. I have done 46 patients, 32 primary, 3 of these rheumatoid arthritis, 14 revisions. One was a fractured ulna and bent stem, and 9 of these revisions had nerve-related symptoms from the previous DRUJ surgeries, neuroma of the posterior introosseous nerve, this dorsal ulnar sensory nerve, or the radial sensory nerve. 2 patients had TOC, and 5 had cubital tunnel syndrome, and 1 patient had a problem with the ulnar nerve. 7 continued limitation in supination and pronation, but the rest gained full range of motion. 2 of these had Madelung deformity, and 1 had Holt-Oram syndrome, and 2 had PRUJ osteoarthritis out of these 7 limited patients. There were no infections in my series, no new nerve issues, no wound coverage or ECU tendinitis problems, and there was no loosening. But remember, my oldest case probably is only 14 years or so. 1 intraoperative ulnar fracture, 1 radius proximal non-displaced fracture, which I treated with conservative treatment. The intraop I will show in a second. 5 patients continued pain. Again, 5 neuroma patients. 1 also has TOCS, and 1 has persistent cubital tunnel. So this is a patient that we had a intraoperative fracture as we were drilling the ulna. As you see, Holt-Oram syndrome goes with significant bowing in the forearm bones, similar to Madelung deformity. And unfortunately, the drill broke as we were drilling, and it broke the distal part of the ulna, and we had to do a longer implant in this patient. This is a Madelung deformity patient who came from Ireland with the implant slightly dorsally placed, so it was irritating the ECU and tissues here. But look at the long screw, which almost I would say 5-6 millimeter out, despite the X-rays looking differently. And it was directly irritating the brachyradialis and the dorsal ulnar sensory nerve. I'm sorry, the radial sensory nerve. And we removed the implant, placed it in a more volar and a better angled position. And this is the implant after it's connected. You can see the plastic ball and the cover in place. This is another patient. This is a patient that is in agony, came for asking basically for an amputation, and this was done to her. First startup was done. When it failed, Achilles tendon interposition was done, and she was having severe nerve symptoms as well as mechanical pain. And you can see the ulnar nerve immediately under the ulna, which was not stable, and basically it was irritating the dorsal ulnar sensory nerve, the ulnar nerve, and then as you see, this heterotopic bone was formed in the Achilles tendon, and we are preparing this for a publication. So the total this radial ulnar implant arthroplasty seems to be the ultimate solution when there's arthritis and instability, and are reported with good results. And I think it's important to measure these screws well with the locking system now. You don't have to go out of the cortex as in this case. And you can see that also adjusting this distance so it doesn't telescope in and out is a very important tip to prevent any failure of this implant. You can also, looking at this picture, I have several patients with total wrist fusion and radioscephalunate arthrodesis that underwent DRUJ problem, which I see as a different joint anyways. That's all I have for you today.
Thank you, Dr. Tuna. I think all your technical nuances of DRUJ implant arthroplasty, I think is very exciting and very informative and useful to all of us. All the steps and the problems you have discussed about before and after the surgery. I think thanks for your wonderful lecture. And we have a lot of questions from the delegates. I think considering the time, we will have one question to all the panelists each, and then probably we'll have the end of the session. The first question to Dr. Zekil Zerenberg about the importance of the distal ulnar attachment of the radioulnar ligament and the importance of wide footprint for foveal attachment. Could you just touch upon those aspects, because most of the reviewers are also seeing live in YouTube and Facebook, so that they may not have access to all the chats which you have. Just a quick thoughts on the footprint of the foveal attachment and your take on the distal ulnar attachment of the radioulnar ligament.
Well, basically, that idea became from a paper published by Shin in the Journal of Hand Surgery in 2017. And basically, they show that the insertion of the ligamentum subcruentum has a broad marginal insertion in comparison with the superficial fibers that only have a circular insertion around the ulnar styloid. And maybe, I mean, that may be important from an anatomical point of view in a case of a reconstruction of the radio of the deep radioulnar ligaments, that we may need to consider that that the insertion, it is not only in one point, instead is all over the fovea. So basically that's the idea.
Yeah, thanks for your clarification. The other question to Dr. Gustavo about the technical aspect. The viewers, they want to know about the location of the isometric point. I mean, you have been very particular about the success remain in isolating, finding the isometric point, especially if you're using the two-tunnel technique. Could you just throw us a few you call technical tips for those readers who are and the viewers who are interested about this technique?
Okay, we usually introduce the shaver first through the pre-styloid recess, and the isometric point is just less than a centimeter from the pre-styloid recess. We start performing a synovectomy, and when you shave the tissues under or below the TFCC, you can start to feel the concavity of the fovea. And then I usually introduce a curette through the pre-styloid recess just to feel the bone and work on the footprint, and you can feel the concavity of this isometric point. If I don't feel bone, I continue with the shaver until I feel bone. And if I still have any doubt, I perform then a distal RadioUlnar Joint arthroscopy.
Thank you, Dr.
Sorry. Sometimes at the beginning, when we started to perform this technique, I always started my patients with the, and after surgery, I perform a CT scan, and I have learned that we always tend to go too much palmar. So when we are performing this technique, we try to go more dorsal, and sometimes I introduce a probe through the 6R portal and try to locate the probe in the place I want to pass with the key wires. So it's a very nice reference to see the direction the key wire must follow.
Thank you for that clarification. The question to Dr. Alex, probably the viewers also want to know, do you have an indication of whether to do a direct or a Sawakapanji based on the age, or do you really feel some other factor, especially in the DRUJ, which makes you that this patient needs direct, this patient needs Sawakapanji? And the other additional question, probably Dr. Tuna and Dr. Alex can together, answer this question. In the case of rheumatoid arthritis, especially DRUJ, what would be the preference of treatment if there's a stable DRUJ? Probably Dr. Alex can go ahead, and then Dr. Tuna can follow.
Okay. First of all, I think this is a very reasonable question. Honestly, I don't think there's a very big difference between doing one technique and the other. The advantages of Sawakapanji, I think they are not so great in terms of function, or if it doesn't work well, it's the same problem. The main thing why you have a failed DARAC or a failed Sawakapanji, probably it's because you have an instability of the ulnar stump, which is symptomatic. Okay, if you have a DARAC or a Majulna, the advantage is that by definition, you do the resection more distal. Okay, so you have probably less chances of having a symptomatic ulnar stump, and in case that you have it and you want to rescue it with an implant, you need a not so big implant during surgery. So right now I'm decreasing the number of Sobekapangis and I'm increasing a little bit the number of very, very distal resections, like matched very distal Diracs. Said that, I have to say that that was my topic, but I not only do this type of resection arthroplasties, and I do implant arthroplasties. The problem is that it doesn't matter the technique that you decide to do, you always pay a penalty. Okay, you always pay a penalty. If you're doing a kind of resection on the distal part of the ulna, your penalty is the chances of having a symptomatic instability, which is something that it's not going to happen always or most of the times. But if you're placing an implant, you're deciding to place an implant probably in a young person. And the bigger the implant is, the more penalties you have potentially to pay in the future. Okay, so your question. I wouldn't take care about the age. I think it's not the most important thing to think about if you decide to do a kind of just simple resection or not so simple, or a Sobekapanghi. I will take care about the technical procedure, it's true, and I will have to have in mind to explain the patient if it doesn't work well, which are the options that I have to rescue it. And also have in mind that the implant arthroplasty is something which is not available all around the world. And this is a fact. This is also a fact. And if you want, I answer the second question, which was about rheumatoid patients. These are the group of patients in which I think the chances of developing a symptomatic ulnar stump instability is lower, in my experience, and we have seen many rheumatoid patients. It's not impossible, but in my experience, it's not a group of patients in which I should take care. In rheumatoid patients, I prefer to do Sobekapanghi because of two reasons. One, it's because aesthetic, it's a little bit better because you have this part of the wrist without a hole. And the second thing is because if you want to rescue something on the proximal row, you have some more bony surface to do it if you do a Sobekapanghi. Okay, and just the last thing about Sobekapanghi in rheumatoid patient, it's said many places that doing a Sobekapanghi prevents ulnar translation of the carpal bones. This is not true because ulnar translation of the carpal bones depends on radiocarpal ligament insufficiency and not because of the ulnar head. Okay.
Thank you. I think well said. Dr. Chuna, can you go ahead? You can add up to this last question about the DRJ instability and the especially in rheumatoid arthritis, and one more question from my side. I was also visiting, a week there in the Mayo Clinic during my international fellowship there. I was seeing this DRJ implant arthroplasty. They were putting the shakers processes. Is there any upgradation of generation, like they said, second generation processes? Do you have any upgradation in the shakers processes, or do you want to comment on that just after your thoughts on DRUJ? Sure. And at the last, could you also comment about being, your thoughts about the arthroplasty? Can you just touch upon, you do DRUJ also address the radial head fracture? You do replacement there? I mean, just a quick, curious question.
Sure. Well, thank you. Well, so many questions. So let's, first of all, let me tell you, the second generation is basically there's a locking. First, size 10 was not available many years ago, so it's a much smaller size. It fits better. So some of those revisions I've done, actually I've done them from size 20 to size 10 with locking screws available now. So that was not available at the beginning. So that's what I meant by second. So what Alex just said is very important. Is it available? Like, is it available for many nations? It comes to the question, is this implant available? Yes, it's a great option, but is it available? So that's when we are like, oh, okay, so now what? So the understanding of DRUJ is a different joint than the radiocarpal or ulnar carpal joint. So that's why if we think that way, some of those answers become more clear, like ulnar translation in the rheumatoid arthritis. It doesn't only ulnarly translate, but it goes volarly as well. That's why Sovakapanchi will not have any effect on that. So you treat that with a different surgery, which is usually, in my hands, it's radiolunate arthrodesis. So that takes care of the carpus. But when it comes to the rheumatoid DRUJ, how do you handle that? Well, how old is the patient? Do they have good bone stock? Are they still working? In the United States, working is a big issue. You need to put them back to work. And I have patients with total elbow, total DRUJ that have rheumatoid arthritis that are still working. Like in an assembly line, I have patients that are still working. Although we tell them to limit themselves with 20 pounds, etc., they will not. I mean, because they can lift. So DRUJ issues I see more around pain is terrible. Okay, I mean, you're in really trouble if they're in pain, but weakness is the other trouble. In my slide, like there's really a few things: pain, instability, and weakness. But that weakness part is important because can they do things? Can they drill? Can they hold a power drill and use that? They will not be able to. If they do it first year, they might be able to, but not later. That's why. And again, geographical differences. I'm from Turkey originally. Like the lifestyle there, lifestyle in the United States, they are very different. Lifestyle in India and lifestyle in Spain will be very different. They are tolerated at the workplace. In the United States, they are not. They will be fired if they don't perform. It's that simple. So that's why you have to give them a different option, which is, I think that's why DRUJ implant arthroplasty as a total, both connected is a great option. Well, what was your fourth question? I missed.
I think I completely have answered all those questions. One, I think, was the second generation. You completely, described about that. The option of rheumatoid arthritis and DRUJ, I think you touched upon that. I think the last question probably partially, answered. Do you replace the radial head in cases where you feel that distal DRUJ, as a gross, unstable there, and then probably would you address those issues also if you have a patient there in radial head fractures?
So yes, I do replace the proximal RadioUlnar joint or the radial head. The thing is, I don't like it because there are no good implants. And when do I do it? For the axial stability of the forearm, you need distal RadioUlnar joint stability, you need proximal RadioUlnar joint stability, and you need the interosseous membrane. And the studies show that you need two intact out of these three. So two of the three still need to be intact. So if your interosseous membrane is damaged, and then if you have a radial head issue, excision, which works great in my opinion, in the PRUJ will not work because of the instability, and it will basically collapse. That's why initially I almost always, like when the injury is fresh, before any scarring happens, etc., I try to replace it. But then when it fails, I will just do the excision arthroplasty. But the same concepts come into play. When they become arthritic or when they become symptomatic in the PRUJ, what do you do about that? It's then we go into the same same dilemma. I'm gonna use a nice word there that you use these soft tissue inner position. Have I not used Achilles? Have I not used triceps? To inner pose Yes, I have. Have I not tried to recreate the annular ligament, etc.? Yes, but the problem is the impingement there. Again, radius, and it's not a problem between the radius and the capitulum. It's a problem between the radius and the ulna. Again, there will be arthritic changes that will basically prevent them from, fully rotating and also lifting. But we will, once you cut the radial head, you will give them good ulnar humeral motion. But the problem exists. So we are hoping for another implant there that will replace the PRUJ, not the radial head.
Thanks, Dr. Krishnan. I think day will come where will be having a webinar on PRUJ rather than DRUJ. I think we'll hope for that. We have plenty of questions. I think we will take one or two questions and then probably we'll wind up the session. One most important question is that I think all of can comment on that. Extensor carpi ulnaris is also one of the vital structures in DRUJ. How vital you feel that? Do you really answer this problem in instability, whether especially if you have a subluxation or while doing a direct procedure or other surgical instability? How would you treat it, the extensor carpi ulnaris? I think that's one of the vital question. We can start with Zekul and then probably with Gustavo and then Dr. Alex and Dr. Nath can go ahead.
Okay, well, in the acute setting, I always tried conservative treatment for an snapping ECU, and that's my first line of treatment. However, if the patient have persistent napping and painful, only those cases I consider surgery or reconstruction. But I mean, any tricks to manage? I don't know if the question is meant for the diagnosis or for the surgical treatment. I'm not sure about that.
Thank you. Dr. Gustavo?
Sorry. Okay. For diagnosis, I always prefer to use ultrasound dynamic evaluation because it's better than the MRI. And if I can verify an extensor carpi ulnari snapping, I always try to, as Ezekiel told us, a conservative treatment, a non-surgical treatment, and if it's not, or if we have, sometimes we have tennis players who are who wants to get back to sport earlier, so we have to perform surgery, and always we try a direct repair with the downwards on the floor of the 6th compartment. But if we cannot perform a direct repair, we always prefer to perform the technique described by by Mark Garcia Elias of the Kaplan Institute, in where he locate the extensor carpi ulnaris tendon inside below the dorsal capsule. So you can use the distal RadioUlnar joint capsule to reconstruct a new Bourgerie, a new 6th compartment, and it's a very good technique to reconstruct the 6th compartment.
Thank you, Dr. Alex.
Well, yes, I also, as Ezekiel said, I didn't get if the question was just about ECU instability and that's it.
And the role in all of the reconstructive procedures. Say, for example, you will be doing a direct procedure,
okay,
and or any other reconstructive procedure. How would you place that ECU? I think ECU is one of the vital structures, especially in the stability of the DRUJ.
Okay. Okay. So, and this has to be answered in seconds, no? This is this is quite difficult. Well, let me just throw some bullets. The first thing, we have commented with Ezequiel. We have shown during many times that ECU, it's a very good dynamic stabilizer in neutral and pronation situation of the forearm, but some cadaveric lab has showed that ECU is much more important in supination, okay? If you think about the position of ECU. And we don't know why, but it's true. And probably this is because ECU has a more straight direction to the carpal bones and more effects on the carpal bones and on the DRUJ in supination rather than in neutral situation or pronation where it has to twist a little bit. That's the first thing. The second thing, when you have acute or traumatic injury just to the ECU, I completely agree. I will try it conservative first. If I'm not able to do that and I have to do surgery, and if it's not possible to do it anatomically, as Gustavo said, we prefer to do the reconstruction that he has mentioned. You place the ECU, you create a small box under the capsule and you place the ECU there. And I prefer that to the procedure using the extensor retinaculum because I think it's a weaker structure, the extensor retinaculum. That's the second thing. The third thing regarding acute injuries is that it's more important the soft tissues rather than the sulcus that you have on the ulnar head, because this has been proven in the lab. So trying to dip a little bit more the ulnar head sulcus, I think it doesn't make sense. And finally, what to do in the different procedures. If it's possible, I think it's better to place the ECU back on its original position, and that means treating the soft tissues properly. So if you do a kind of excision arthroplasty, always try to not to free the ECU from its fibers that are connecting the ECU to the ulnar head, even if you are resecting the ulnar head, because by placing back the capsule, the ECU is going to be in an anatomical position. If you do a Sobeca-Pangi, what you have to do is do the arthrodesis and placing back the ulnar head as if it was in supination, because then the ECU is going to be dorsal. And then it seems to be a little bit more stabilizer of the ulnar stump. If you do that, be careful of leaving an ulnar stump which is very sharp in the dorsal part, because it can damage a little bit the tendons on the dorsal part. So if you do that in the distal part of the ulnar stump with a ronger or something, try to level this up a little bit. And then finally, with arthroplasties, then I raise a question to Tuna. It's when I use the aptis prosthesis, the most complaining complication and that I cannot prevent from, or I cannot imagine that it's going to happen in that specific patient, it's ECU problems. So I try to free the ECU when I place an aptis implant, but still I don't have I don't know how to say that, but the perfect solution of preventing ECU problems. And I'm very interested because I've seen in your presentation that you have 0 problems with ECU in your series, which is something that it's giving me a lot of headaches. What to do with the ECU with a total implant?
All right, I'll come to that. Let me say a couple of things about the ECU. ECU tendon, most of the time, as a degenerative tear, I have seen against the triquetrum. So you will basically see a little bone spur there with the working wrist. You will have a split tendon or a tear, degenerative tear from irritation. So what I do is I go in, do the debridement, repair the tendon, and then also shave the triquetrum. Now, ECU compartment is there's the retinaculum, but we keep focusing on the subsheath, but if you look at it, there's a sheath around the ECU that stabilizes the ECU, I think more important than the retinaculum. So if that's ruptured acutely, it's a big problem. I have seen couple patients like that with severe swelling, etc. So what I did in those is try to repair that sheath and then also reinsert the retinaculum that is torn from the ulna. and it ended really well. But I can't, like, it's probably 2 or 3 I have seen over the last 20 years. I'm in hand surgery. Now, when it comes to the DARA, etc., I really, it's like a, so Alex, this is probably the answer. When Dr. Shekhar does it, he basically opens it from the ulnar side of the DRUJ, and then he will always create these flaps and then protect the head with the flap. The ones I open it like in the classic textbooks through the 5th compartment, so I don't really bother the 6th compartment at all. So I go immediately radial to the 6th compartment. And then if there's previous surgeries, if there's a very bulky head, etc., I've prepared these retinacular flaps, basically from the 2nd compartment to the 6th compartment. And then I will use those to cover the head. And I always put the implant volarly rather than dorsally. So I think that, and the ones that I have revised, that's one of the most common problems, because it's basically sticking out dorsally. The implant itself is sticking out dorsally. So keeping the implant volarly and keeping the implant small, I think is extremely important. 1, 2, still, if there's coverage issues like the last lady I showed with the Achilles interposition, she doesn't have any soft tissues left. So we had to prepare flaps for her to cover the implant head, so it doesn't. So again, I try, if it's primary, I don't touch the ECU at all. Now, Dr. Shekhar has different opinion about the ECU. He says because the DRUJ is replaced, there's no translational issue, so he will open I believe he recommends opening the ECU sheath completely. Again, because it's replaced, there's no translational force according to him. It's a stable, the ECU stays stable there, but I don't get into the 6th compartment at all. When I'm done, I am able to bring it back without any significant repair if you go through the EDQ. And then I will leave EDQ out. But when I leave it out, again, the distal retinaculum is still intact. So I'm not like completely destabilizing it. So that's how I handle it, how I have always handled it.
Thank you, Dr. Tuna. Please go ahead.
Can I make a comment? Just a couple of things that I think it's quite interesting for the people that are listening that Tuna has already said. The first one, it's keeping the distal part of the extensor retinaculum because this is a stronger one. It's always much more stronger on the distal part, the extensor retinaculum. So whatever the procedure you do, whatever the surgery you do, if you have you have to think about that. The second thing, it's talking about the floor of the ECU. And this is very important when you arrive to the ulnar carpon area. We saw when we studied the mechanoreceptor and the sensory innervation of this area that the floor of the ECU, first of all, it's completely or directly in contact with the ulnocarpal space. So if you have problems in the ulnocarpal space, and you can see it from arthroscopy from inside, the floor of the ECU is there. And it's very well innervated. It's very richly innervated. So you have to have that in mind. There are some problems that are connecting the ECU floor with the ulnocarpal space. And those problems usually are painful because this area is very richly innervated. So this division between extraarticular problems and intracapsular problems, this division is partially true when you're talking about the ECU. Okay, but if you're just talking about instability of the ECU or synovitis, think that in a specific group of patients, as tennis players like Gustavo said, ECU is the most important reason for extracapsular ulnar-sided pain, and that means 1 of every 4 patients. And apart from from ultrasound, there's a very easy maneuver to detect that, which is just the test in which you try to separate the fingers and you do a co-contraction of the ECU. When you have a synovitis, this is extremely sensible. So those 3-4 ideas of the ECU. The floor is important. It's connected with intracapsular problems. It's a very big source of extracapsular pain, and you can diagnose that easily by clinics and ultrasound. I think this is very important. And the distal part of the extensor retinaculum is the most important from the anatomical point of view.
Alex, I forgot to mention that when the extensor retinaculum is missing, or when there's the sheath I was talking about becomes totally unstable, actually I do stabilization techniques using tendon. So what I do is I do a retinaculum reconstruction. I will drill 4 holes and then pass the palmaris longus tendon in an envelope shape, and then suture it to each other as tight as possible with only one freer elevator inside the compartment. And then I will try to hold the ECU in place with the freer and put it as tight as possible, and then we'll just stitch it. That works well for me. There's one thing I do differently than I keep people in 60 degrees of supination, not necessarily in the neutral position, which is, to me, the neutral position of DRUJ in all these studies are the anatomical position, which is 60 degrees of supination. So I will keep that whenever I do procedures like a TFCC. I saw the TFCC reinsertion. I do a very similar reinsertion, although it's a different technique. I will keep them in 60 degrees of supination so that it stays, the TFCC stays in the neutral position. And I will put them again for a brief period in a little bit of supination, then we'll bring it back. The foveoplasty, or whatever they call it, actually, they play with the ulnar groove for the ECU groove. I think is a bad idea, and it should not be done because I believe Alex pointed to that as well. The floor of the ECU, you should not enlarge or shave or try to make it deeper, etc. I don't think that's a good idea. But I see that comes to my clinic as a complication, and then now you have to cover it with a flap, with some retinacular flap, and then create the ligament reconstruction. It's a big problem.
Thank you. I think we have very informative and loads of information about the DRG this evening. Before we close the session, quick closing remarks from all of you. Quick 20-30 seconds closing remark. Probably can throw us what's the future of DRUJ? We can start with Nikhil.
Well, probably we have to go farther into the knowledge of the proprioception of the DRUJ to try to improve not only the surgical technique, but also to improve our ideas of conservative treatment with the dynamic stabilizers of the joint. Probably that's gonna take us to the next level in the conservative management of the DRUJ. I cannot go in 20 seconds further into surgical treatments.
I missed the question. What's the question?
The question or the comment is that quick closing remarks about this webinar and the future of DRUJ. I think I cannot mean you cannot have in 20-30 seconds to answer it, but probably to the to the audience we will have a day. Dr. Gustav.
Yeah, I totally agree with Ezekiel. We have to study more about the proprioception of the distal RadioUlnar joint and conservative treatment. And we, like Alex told us, we should avoid to make open and big approaches when we have some problems. And so I think arthroscopy is a very useful tool to still improve some procedures like ATSE or Vicente Carratalar reconstruction when we have very bad soft tissues of quality. Yeah, I think that's it. Will be the future.
Thank you, Dr. Alex.
Well, a couple of things have been already said. One of the conclusions, if you want to have headaches, see a lot of patients with ulnar-sided pain. This is one of the conclusions, for sure. And the second conclusion, I think there's no perfect reconstruction for the DRUJ. You always have a problem. It doesn't matter the type of treatment that you choose. And finally, I just reinforce the idea that probably we should focus a little bit more on conservative treatment. Yes.
Thank you, Dr. Tuna.
Well, I will say the future of DRUJ is education. And as you educate people more about the distal RadioUlnar joint, the problems can be recognized earlier, fixed before arthritis and instability hits. This education is not limited to what we spoke today, but also treatment of distal radius fractures and all the risk trauma associated with it, so that we prevent it before it comes to the Fugazi state, where it's we cut this, we interpose this, we do a little more, let's shape it a little better, etc. I don't think we need to get into that, so that if we don't get into any of that, I think we are out of trouble.
Thank you. That's all we have viewers today. I mean, this was a fantastic evening, probably morning there. We enjoyed and learned many things, right from Ezekiel about the anatomy and the need for the ligaments and interosseous membrane stability, to Dr. Gustavo about the arthroscopic technique and especially the two focal important points for the insertion of the bony tunnel, with Dr. Alex, especially exaggerative discussion about the Dirac's, the Sawakapanji and the principles behind it, and of course with Dr. Tuna, overview about the DRUG implant. We had a great day today. I wish and thank you one and all for this wonderful opportunity. Really, we had a nice event this evening. Wishing you all safe and healthy. Stay safe. And thank you. We'll meet again in the future webinar. Thank you once again. Thank you very much.
Thank you. Thank you.
Bye.
Thanks, Dr. Gustavo. I think it's a fantastic program. Really enjoyed. We like to have some more repeat.
Thank you, Jerome. Thank you, Alex. Thank you,
all those
Tuna.
faculties.
Thank you, Ezequiel.
They're really excellent.
Ezequiel thought to get Tuna here.
Yeah, it's great. We have a lot of questions to answer, but then considering the time, we have to bypass those questions. We should have a regular webinar like this with the same faculty. I think we have a wonderful discussion. What is more important is to understand the readers' common problems, and then keep educating them. Even though they think it's a headache, but we are trying to solve some sort of portion of the headache so that they can have a perceptible knowledge about DRUJ and can have a treatment principle behind it. I think a great thank you to all of you for being wonderful session.
Thank you very much.
You're welcome.
Gracias, Alex.
Thank you.
Gracias, Alex.
Gracias.
Thank you.
Un beso.
Vamos.
Chao. Podemos hacer un Zoom o lo que sea para enseñarme aquello, pero no ahora, que me van a cortar el cuello. So, sorry for that. I'm just saying that my family is going to kill me. And I know it's not going to be the only case. Yes. No.
Yo también.
Me van a cortar los huevos, tío. Directamente. Hablamos,
Bueno,
¿vale?
chao, chao. Bye,
Venga,
Jerome.
besos. Bye.
Thank you.